ICU. And as you can see, this was really a new world for us. And now we are facing a second wave. First of all, I would like to show you how we organized in the hospital against the COVID-19 pandemic. And I use this analogy like the anatomy of a fort with barbicans and moats. And this is the Diamond Fort, the Sleepy Giant, which is a fort of the 18th century on the hills around Genoa. And you can see an old map of Genoa with the old harbor. And this is characterized by different barbicans and different modes. So we organize different modes, so different intensive care at different levels, and we organized a new more when the previous one was almost full. These are the data from our study on the seroprevalence in Liguria in blue. And as you can see here, we got a prevalence from 15 to 20% of the patients. While in Lombardia region, as you can see in red, just above in the north of Liguria, one of the most hit in the first wave and also in the second wave, the prevalence was again between 6 to 14%. So we had a very high seroprevalence in Liguria. That was the reason why we had to increase the number of the ICU beds for 3 times more compared to the regular status. In Lombardia region, there are 11 million inhabitants, and the rate of intubation was 34 intubated patients for 100,000 population. While in the Liguria region, we have 1,500,000 inhabitants, and we got a rate of around 29-30 intubated patients for 100,000 inhabitants, very similar to what recorded in Lombardia. These are some of our data that we got in the first wave, treating more than 400 patients in our hospital in the world, and 18% required intubation, and 152 intubated patients, almost 37% of the overall region. The mortality at 28 days was quite good, in our opinion, around 26%, with ICU mortality of 36%, which was exactly the same as an hospital mortality of 36%, which compared to what has been reported in the literature with ICU mortality higher than 50%, this data appears to be extremely successful. In this study, we showed the clinical course of SARS-CoV-2 infection, and as you can see, there are different issues to be discussed. First of all, there is a progression of the severe disease with a median time of death at 21 days for symptom onset. Further, among 100 patients percent with symptoms, almost 16 to 20% require hospitalization, and 5 to 12% are intubated with a prolonged mechanical ventilation need of around 6%. So almost half of the patients intubated require prolonged mechanical ventilation, while a minority of the patients were. Further information was that the average time and range of mechanical ventilation, as shown in the orange bar, was between 16 to 28 days of mechanical ventilation. And further, the progressive increase in antiviral total antibodies detectable and progressive decrease in the SARS-CoV-2 RNA detectable by PCR. This is related to the fact that viral shedding longer than 21 days was associated with higher risk of mechanical ventilation and longer length of hospital stay. So as I'm used to say, we treated the unknown, the impossible, the unimaginable. This is the SARS-CoV-2 virus that, as we know, the main mechanism of action is the link with the human ACE2 receptor, which activates different molecular processes. And at the beginning, the coronavirus disease 2019 COVID-19 pneumonia was considered just a pneumonia from mild to moderate to severe illness. Further, other studies recognized that other mechanisms related to the coagulation side were extremely important. In this slide, it showed that the Activation of cytokine storm may be related to different activation of interleukins and inflammatory modulators and immune cells, which promotes alteration in the alveolar capillary barrier with fluids in the lung. Further, there's activation of the fibrin clot and platelet clot with increases amount of the dimer, and this is also related to the vascular leakage. So this was one of the reasons why the SARS-CoV-2 pneumonia was renamed like macroclots. We went further and we clearly showed that COVID-19 is a multi-organ disease. This is one of the first studies on this issue, which was replicated in many others right now. So the damage was not only related to the lung and the coagulation, but also to the heart, to the kidney, and to the brain, and in some minor circumstances to the liver and the gut. So we renamed this disease like a MOTS-CoV-2, so multiple syndrome CoV-2. And this is well represented in this picture with Dr. Valbusa, our cardiologist, with the cardiac ultrasound, which was performed in all our patients every day, and the patient connected to a ventilator to support the respiratory function, with different pumps for different drugs and vasoactive drugs, a renal support machine, and in this case, even an extracorporeal membrane oxygenator. These are data gained from our studies on more than 300 patients with an average age of 71 years, since the population in Liguria is quite old, and we found that RDS development in these patients admitted to the infectious disease ward was around 36–37%, with the need of mechanical ventilation on 35%, and ICU admission of them around 20%. And all of them will require invasive mechanical ventilation. However, septic shock or CRRT were used only in 2 to 4% of the patients at the beginning of the disease. The ICU length of stay and the hospital length of stay was in the median 12 days, and the in-hospital mortality overall was around 43%. So compared to our mortality in the intensive care means that the role of intensive care units was a key role in the treatment of COVID-19 pneumonia. We also identified several risk factors associated with mortality, like interleukin-6 with an odds ratio of 4.4, the RDS development, so lung worsening in terms of oxygenation, again an odds ratio around 4.4, a presence of heart disease with an odds ratio of 3.2, and age with an increased risk in older patients. We used and treated with different therapies and emerging therapies, and I would like to concentrate a little bit my attention on corticosteroid and heparin. We also investigated tocilizumab, which is an anti-interleukin-C receptor, and we also used the remdesivir. We found that the use of methylprednisolone or individually used were associated with better failure-free survival and even better outcome. So we believe that the use of anti-inflammatory drugs were a good choice in this patient, especially when used in the early phase when patient required an oxygen need. When we look at the different effects of the drugs, we did not find any significant difference between tocilizumab or steroids, or even combined. Even the population of patients investigated was not so large. So this suggested us that steroids alone were the best choice in these patients. And in fact, when we look at the correlation between anti-inflammatory drugs and blood systemic infection, we found that the increased risk to develop BSI occurred around 12 to 15 days after intubation. And when we look at the survival probability, this was relatively high, since the mortality at 24 days was 27%, even in patients with developed BSI. When we look at the risk factor for BSI, as you can see here, this was mainly associated with the adjusted multivariate analysis with the anti-inflammatory treatment. And specifically, the association of methylprednisolone and tocilizumab increases the risk of BSI of up to 10 times more. So that's why we believe and we practiced the use of corticosteroid alone without tocilizumab in those patients. Another important point is the role of anticoagulation protocol. This is our anticoagulation protocol characterized by the clinical evaluation, the electrocardiogram, the D-dimer, the troponin, the BNP, and the daily measurements of the D-dimer. We separated the patients in 3 different risks. Low risk, when the D-dimer was below 1,000 with no clinical events, we used prophylactic enoxaparin at 4,000 units a day. And then we look at the improvement or not in the D-dimer and clinical status. If yes, we continue with prophylactic enoxaparin for 1 month after discharge, of course considering the bleeding risk. If no, we reassess it to escalate to the next risk stage. In the intermediate risk patient with D-dimer higher than 1,000 but no clinical events, we always perform an echocardiographic evaluation and look for the right ventricular impairment. In case of no right ventricular impairment but intermediate risk, we use therapeutic enoxaparin at 4,000 times 2 or 6,000 times 2. If there was echocardiographic right ventricular impairment not related to PEEP, we escalated to next risk stage like CT angio. And in fact, when we have high risk with D-dimer 1 10,000 and increase BNP on troponin in the clinical event and or echocardiogram with alteration suggesting right ventricular impairment, of course, we perform an electrocardiographic evaluation, and according to the no right ventricular dysfunction, we use therapeutic enoxaparin or even intravenous heparin and eventually CT angio. In evidence of thrombosis, of course, we started immediately with thrombolysis and heparin, and in case of right heart ventricular dysfunction, we use therapeutic enoxaparin with intravenous heparin, and eventually we performed CT angio. So CT angio was very important because in that case we were able to identify quite early patients who were deteriorating, and in that case we started very early thrombolytic drugs, followed by starting warfarin, so Coumadin, under strict follow-up and cardiological evaluation considering the bleeding risk. And in the follow-up phase we use new anticoagulants in these patients. The main monitoring were the D-dimer, performed twice a day, the activated factor 10, and the thromboelastogram. Now we go to discuss the pulmonary and extrapulmonary RDS. A few years ago, with Professor Rocco, we developed concepts of different injury in pulmonary and extrapulmonary RDS. In pulmonary RDS, the insult is coming directly to the alveoli, impairing the alveolar side. And the most common causes is direct pneumonia. Then we have extrapulmonary RDS, when we have an extrapulmonary foci with inflammatory mediator through the blood vessels, which may alter the alveolar capillary barrier. And this is more likely to be in sepsis. In clinical practice, in traditional RDS, sometimes it's not so easy to differentiate primary versus extrapulmonary RDS, since pneumonia may be joined with sepsis. We also found that pulmonary RDS compared to extrapulmonary RDS were characterized by increased damage of the alveolar epithelium and altered type 1 and type 2 cells, prevalent alveolar neutrophils and apoptotic neutrophils, with a presence of fibrinous exudate. Alveolar collapse was lower in pulmonary RDS as compared to extrapulmonary RDS, with increased and prevalent local interleukin. Further, in pulmonary RDS, the interstitial edema was lower than extrapulmonary RDS, while collagen fiber and infiltration were higher. The endothelium in the capillary side was almost normal in pulmonary, while more damage in the extrapulmonary RDS, while interleukin and TNF-alpha were much more increased in extrapulmonary as compared to pulmonary RDS. We performed several studies on post-mortem findings in COVID-19 pneumonia. This is a typical normal lung, which is pink, soft, and not edematous. This is a typical RDS lung, hemorrhagic, edematous, and with a patho-like pattern. While the COVID-19 pneumonia is much more fibrotic, the color is yellow-brown, with hemorrhage area, fibrosis area overall widespread in the lung, and bulle in the mediastinal and pleural surface. We performed a study by using cryobiopsy by our interventional pulmonologist, in which we use fibroscope to sample part of the lung from the ventral to dorsal lung after 20 minutes of death and during mechanical ventilation. So this technique allowed us to perform biopsy in the patients just after death, and is completely different from conventional autopsy that were performed 5 days after death. We identified patients who died almost 25 days after intubation, an early death pattern which can be combined with the our CT finding. In case of very moderate alteration of the CT, we found, you see the upper panel, an alteration in the epithelial cells in brown and with black arrows, no alveolar edema, as you can see in the red arrow, and just a hyaline membrane in pink areas. Then a mid-diffuse alveolar damage pattern with vascular lysis and initial pneumolysis with initial fibrosis in the ground glass poorly aerated areas typical of COVID-19 pneumonia. Further, in the late DID pattern, we found a completely alteration in the anatomy of the lung in the white areas at the CT scan with complete vascular lysis but not thrombosis. Finally, the honeycombing in the lateral part of the lung, which was characterized by fibrosis and complete destructure of the anatomopathology of the lung. And in the blue area, you can see the mucosinosis in the alveoli, and in the last box, you can see the epithelial cells in brown, which can be also altered, and inside the interstitium, which is fibrotic. The red cells are the smooth muscle cells, which will identify and suggest a complete deregulation of the fibrogenic process in COVID-19 pneumonia, at least in the later stage. So the main alteration in this disease that we found at anatomopathology study were pneumolysis, vascular lysis, alveolar cell infiltration, alveolar mucosinosis, and fibrosis. We identified at the CT scan 3 different phenotypes. The phenotype 1, as you can see here, characterized by multiple focal overperfused ground glass opacities and normally aerated areas. These patients are more likely to be supported by non-invasive respiratory support and don't require intubation in most of the cases. Then we have the phenotype 2, more rare, with asymmetric atelectasis and peribronchial opacities, unhomogeneously distributed and hypoperfused, associated with phenotype 1. And further, the phenotype 3, characterized by patchy RDS-like pattern, unhomogeneously distributed with hyper and hyperperfused area, which may be associated or not with phenotype 1. What we found that in critically ill patients who required intubation, phenotype 1 was rare, while phenotype 3 was the most frequent. And phenotype 3, with time of mechanical ventilation, progressed in pneumolysis, vascular lysis, fibrosis, and complicated with overinfection. We look carefully at the regional perfusion. This is the typical distribution of regional perfusion in traditional RDS, with high VAQ in the non-dependent lung regions, low VAQ in the middle part of the lung, and true shunt in the lower part. And the regional perfusion may be altered due to different mechanisms, like vasoconstriction, plus endothelial swelling or obstruction, swelling or vasoconstriction and endothelial swelling or obstruction with vasoconstriction plus endothelial swelling, obstruction, or collapse in the more dependent part of the lung. And 3 different factors may influence the regional perfusion, like hypoxic pulmonary vasoconstriction, airway pressure, and posture. This is the typical distribution of regional perfusion in traditional RDS. In red, identifies areas with more perfusion, while in blue, areas with less perfusion. And as you can see, in most of traditional RDS patients, the distribution of perfusion in the dependent part of the lung, where we observe atelectasis or consolidated areas. So the proportion of perfusion to boxes with fractional water higher than 0.7 is associated with lower amount of oxygenation. So independent lung region consolidation and atelectasis are characterized in the traditional RDS patients with gravitational regional perfusion, so hypoxia in traditional RDS is mainly explained by true shunt. So we performed a study on regional perfusion and aeration by using a dual energy computed tomography in COVID-19 patient. And as you can see here, the first patient that we analyzed, and this was the first CT perfusion that we performed. So this was able, we were able with this technique to identify pulmonary gas volume and pulmonary tissue volume with a regional distribution in the lung, like in the CT scan, associated with a pulmonary blood volume redistribution. We found that in normal lungs, the lung weight is around 800 grams, in RDS lung 1 kilo at 800 grams, so the excess tissue in traditional RDS is around 1 kilo. In COVID-19 phenotype 1, the average weight was around 1 kilo and 100 grams with an excess tissue mass of around 300 grams. So COVID-19 phenotype 3 was characterized by a much higher lung weight, around 1 kilo and 600 grams, with an excess tissue mass of around 800 grams. So the excess tissue mass in traditional RDS in the COVID-19 patient is quite similar. Then we look at the distribution of shunt, gas-blood ratio, and perfusion defects. First of all, you can see that the shunt was around 10% in the whole lung, with a wide range from 3 to 5 to 30%. And most of the shunt, of course, was related to the non-aerated areas. Interesting, when we look at the gas blood, when it's lower than 1 means low VQ areas, higher than 1 is higher VQ areas. You see that in the non-aerated areas in red was mostly associated with low VQ areas or shunt. Interestingly, the poorly aerated areas, the ground glass area, were characterized by 2/3 by low VQ areas and 1/3 of high VQ areas, while more or less in the normal distribution were the hyper-aerated and normally aerated areas. When we look at the perfusion defect, which means in the poorly aerated area, higher dead space, while in the non-aerated areas, less perfusion in that areas with thrombosis, as you can see, was mainly related in the poorly aerated and non-aerated areas, respectively. When we look at the difference between survivors and non-survivors, we did not find major difference in terms of shunt and non-aerated areas, but as you can see here, there was a marked difference in the distribution of low VQ and high VQ areas in the poorly aerated tissue, which makes a particular area of interest when we have to differentiate these two types of patients. And interestingly, as you can see here, in the non-survivors, there was an increase in the area of the high VQ in the poorly aerated tissue as compared to the survivors. And this is also represented in the perfusion defects, which were much higher in the non-survivors in the non-aerated areas, which means that more thrombolytic areas were present in the non-aerated tissue. Interestingly, we found some difference also between the patient who required intubation and the patient in CPAP. And you see that the distribution in the poorly aerated areas and the low VQ and the high VQ area were much more evident in the intubated patients as compared to patients who needed only non-invasive ventilation. So to conclude from here, the poorly aerated areas play a relevant role in terms of low VQ or high VQ and are associated with survival and the possible need of intubation or non-invasive respiratory support. We look also at the distribution of effect of PEEP, and we investigated 2 levels of PEEP which are commonly used in clinical practice, PEEP 8 and PEEP 16. And as you can see, we found no changes in the total lung weight. This is different from traditional RDS when used the higher level of PEEP were associated with a reduction in total lung weight and distribution of lung water from the alveoli to the capillary vessels, while the gas volume increase of around 400 milliliters, which was equivalent to the increase in total lung volume. When we look at the distribution of CT compartments from -900, hyperinflated, -900 to 500, -500, the normally aerated, -500 to +100, -100, the poorly aerated, and -100 to +100, the non-aerated, there was not much difference between the 2 levels of PEEP. And in fact, when we look at the decrease in the hyper-aerated tissue and normally aerated tissue with increasing PEEP, we found just an increase of 2 to 3%. So overall, we found a poor alveolar recruitment with higher PEEP up to 16 in less and more severe cases of COVID-19 pneumonia. Further, the recruitable tissue was around 30 grams, which is equivalent of only 4% of the chest tissue. On the other side, in the traditional RDS, the recruitable tissue is around 200 grams, which is equivalent to 20% of the chest tissue. So overall, we found a very poor potential for recruitment in COVID-19 patients, and it was not different in phenotype H with low compliance or phenotype L with high compliance. Means that respiratory mechanism does not provide any information of possible recruitable or not recruitable. Further, there were no difference between patients who developed a ventilator-associated pneumonia or not, or in survivors and non-survivors. Overall, we found that the increase in the hyper-aerated tissue with application of PEEP 16 compared to PEEP 5 was associated with the normally aerated tissue at PEEP 8. So higher was the amount of normally aerated tissue at PEEP 8, so more aeration. Higher was the increase in hyper-aerated tissue when we apply higher PEEP. Conversely, a lower amount of normally aerated tissue at PEEP 8 was associated with less increase in hyper-aerated tissue at PEEP 16. When we look at the effect of PEEP at two levels of FI2, 50% and 100%, you can see that we find a minor response to PEEP only at lower level of PEEP of FI2. But further, if you compare the level of oxygenation at PEEP 8 or PEEP 16 at 100%, you see that oxygenation was higher at PEEP 8 with higher FI2 as compared to PEEP 16 at lower FI2. So our data suggests that increasing FI2 is much more effective than increasing PEEP in COVID-19 severe RDS pneumonia. Further, the decrease in shunt with PEEP was very minor. While it was extremely important to show that in all patients, the increase of PEEP 16 was associated with a reduction in respiratory system compliance and thus an increase in driving pressure since the tidal volume was constant. Then we look at the effect of prone position. Prone position can be, the improvement in oxygenation in prone position can be explained by different mechanisms. The first mechanism is that when we prone the patient, then there is no change in the consolidated RS, and the improvement in oxygenation is explained by a reverse or flow diversion of regional distribution of perfusion. And this is not associated with any change in regional ventilation, VA, so the improvement in oxygenation is associated with an increase or no change in PCO2. On the other side, as it occurs more frequently in traditional RDS, when we prone the patient and we observe a recruitment of these atelectatic areas in this case, this is also associated with a real increase in oxygenation, but also an increase in regional ventilation. So associated and paralleled by a decrease in PCO2. In COVID-19 patients, we performed CT scan in supine and prone position in 12 patients. And as you can see here, we did not find any major changes in the distribution of densities, that they remain most in the dorsal part of the lung, independent from the position. So we suggest that the main mechanism explaining the improvement in oxygenation in prone position was the flow diversion and not alveolar recruitment. These are our clinical data. As a summary, the prone position was associated with a reduction in lung volume, increased tissue mass, and redistribution of perfusion with no alveolar recruitment. We found similar results when we applied prone position in non-invasive and invasive mechanical ventilation. We performed prone position overall in 34% of the patients, but only 40% of the patients improved oxygenation, so more than 20% than baseline during prone. And more importantly, only 20% of the patients maintained improvement in oxygenation when repositioned as supine. But 77% of the patients increased the PCO2, and we have to consider the possible poor effects on saturation of oxygen. So lower saturation at a lower level of pH, so increased level of PCO2. We have always to exclude thrombosis for possible pulmonary thromboembolism before to turning patient prone, and this maneuver was associated with increased healthcare professional demanded workload. Further, we found no evidence that prone position improved survival, even these data were not randomized. Now we can modelize the effect of high PEEP and prone in different conditions. In normal subjects, we observe a vertical gradient of regional aeration from non-dependent to the dependent part of the lung, the blue circles, with more aeration in the dependent part of the lung. When we apply PEEP, we squeeze the capillaries, especially in the non-dependent part of the lung, and we overinflate the alveoli. When we prone the patients, we redistribute the distribution of aeration from ventral to dorsal, and we maintain a higher perfusion in the dorsal part of the lung. This is very similar to what happens in RDS, and you can see here in the black box the collapsed areas more perfused, which explain more hypoxia. So in traditional RDS, we have an alteration in the alveolar capillary barrier with edema, atelectasis, lower compliance, and higher perfusion in the dependent atelectatic lung regions. So when we apply PEEP, as you can see here, we have recruitment at higher pressure of the lower atelectatic lung regions, in which is maintained perfusion. And this is the main explanation of increasing oxygenation. A similar mechanism occurs in prone position with recruitment of atelectatic areas and maintenance of perfusion in the dorsal areas. So the response in oxygenation by PEEP or prone position in traditional RDS is associated with better aeration and recruitment, but not perfusion distribution. This is what happens in COVID-19 type 1, characterized by ground glass area poorly aerated in the blue circles, and the consolidated area in the black or purple lung circles, with thrombotic and non-thrombotic areas with hypo or hyperperfusion. And as you can see in the COVID-19 pneumonia, is a typically primary RDS with pneumo and vascular lysis, gas volume substituted by cellular necrosis, cellular infiltration, and fibrosis, with consolidation as shown here in the dashed black circles. So we have a higher perfusion in non-dependent lung regions with poor and no recruitment with higher pressure, and also when we prone the patient. As you can see here, the consolidated areas remains consolidated, of course, in the dorsal lung regions, with possible changes in the distribution of perfusion. So the response in oxygenation with PEEP or prone position in COVID-19 is associated with a redistribution of perfusion, but not better aeration. So hypoxia in COVID-19 overall is due to lower VQ in the poorly aerated lung tissue due to increased perfusion, to higher shunt in the non-aerated lung tissue with microthrombosis vascular lysis effect, which may be at least within a certain threshold partially protective towards a further deterioration of oxygenation, and higher VQ in poorly aerated lung tissue with increased ventilation ratio. So in COVID-19 type 1, we can observe the so-called happy hypoxia, characterized by higher compliance with less inspiratory effort, low VQ, and the poorly aerated tissue, the ground glass area, which respond to higher FiO2. On the other side, in the COVID-19 type 3 patient, we have sad hypoxia with lower or higher compliance, with less of higher inspiratory effort, in which hypoxia is mainly characterized by shunt, due to lower ventilation or no ventilation in non-aerated lung tissue. This is poorly responsive to higher pressure and again more responsive to higher FiO2. So overall, less is more, and the concept is primum non nocere, and we suggest in this patient to use the ventilatory management with a closing down the lungs and keeping them resting to minimize ventilator-induced lung injury, with lower tidal volume, lower plateau pressure as much as possible, lower PEEP, and lower driving pressure. We should just gently ventilate the aerated lung, keeping the consolidated lung at rest. So we should target on the minimal PEEP for minimal saturation of oxygen between 88 to 95% and a PO2 between 55 to 80 millimeters of mercury. And this may be also associated with minimal right ventricular impairment, which is very important, especially in these patients. We have always to remember when we minimize oxygenation with this technique, the Bohr effect. The Bohr effect, as you can see here, is the lower saturation at lower pH and higher PCO2 with low or high PO2. So we have to control pH and PCO2 in order to minimize the possible reduction of saturation, especially at the lower level of oxygenation due to the Bohr effects. The other factor is the minimization of oxygenation strategy and the amount of hemoglobin in oxygen delivery. Here you see the distribution of oxygen transport that I remind you the minimum acceptable level is around 600 to 700 milliliters per minute. In different conditions of PO2, different hemoglobin from 7 to 13 and different cardiac index from 2 to 6. We found that if cardiac index is equal to 2 liters per minute per square meter, oxygen transport anyway is not enough independently from the level of hemoglobin. So we should keep the cardiac index to a higher level. If cardiac index is between 4 to 6 liters per minute square meter, oxygen transport is enough with hemoglobin around 10 to 13. And only if cardiac index is equal to 6 liters per minute, so very high, oxygen transport is enough with hemoglobin also be low as 7 grams per deciliter. So we should maintain a cardiac index between 4 to 6 liters per minute and then hemoglobin between 10 to 13 grams per deciliter. So as discussed with our colleague, Professor Kalesha Zubayeta in Bolivia, it could be a possible role of erythropoietin in these patients. Now I show our three flow chart of treatment for non-invasive respiratory support in COVID-19 patient, ventilator management and weaning. Regarding the non-invasive respiratory support in this patient in the ward, usually we measure saturation in the room air and we look at the saturation of oxygen. If it is higher than 95%, we reassess in 6 hours. If it is lower than 95%, we perform a 5-minute test with oxygen at 15 liters per minute with reservoir. If oxygen saturation increases more than 95% or PF ratio higher than 200, we reassess in 4 hours. If it is remained below 95% or PF ratio is below 200, we used LMS CPAP, but also high flow oxygen inhaler therapy might be used with a PEEP level of 10 centimeters of water FI to 60% for 3 to 6 hours. If patients improve, so oxygen saturation is going up more, higher than 95% of PF ratio higher than 200, we continue LPS CPAP. If its oxygen saturation remains below 95% of PF ratio below 200 or respiratory rate above 28 breaths per minute, we believe that we should early intubate and proceed to mechanical ventilation. Other factors has to be considered like low Glasgow coma score, hemodynamic instability, lactate higher than 3 milliequivalent per liter, and of course, as I told you, respiratory rate above 28 breaths per minute, even during LMS CPAP. Other signs are the accessory muscle activity, the reduced PCO2, which is very important, indicating excessive effort from the patient. The lung imaging and diaphragmatic thickness may also be evaluated. By using CPAP helmet with this protocol, we avoided intubation in 83% of hypoxemic COVID-19 patients. When we intubate the patients, of course, we look at the level of hypoxia, and most of the patients presented a PO2 even below 55 millimeters of mercury. Then we set PEEP at 10 centimeters of water, and sometimes we used inhaled nitric oxide. We used 2 ranges of PEEP in the phenotype 1, mainly 8 to 10 centimeters of water, and these were more responsive to inhaled nitric oxide, or no response in inhaled nitric oxide, in which we use a PEEP of between 11 to 13, but not higher than 15. If there is an improvement, of course, we consider anyway prone position, especially in phenotype 2 and 3. If there is no improvement, we consider angio-CT with possible thromboembolic cause to be excluded. Finally, it's very important to have a clear protocol for weaning extubation. This is our protocol. First of all, we have to check that you wear personal protective equipment, and we have to choose, if possible and if available, negative pressure room if available. Then we perform a PSV ventilation with pressure support at 8 centimeters of water, PEEP of 6 and FR2 between 0.3 and 0.4, with an oxygen target between 88 to 94, a PF ratio above 200 and respiratory rate below 20 breaths per minute with good chest imaging. First, we performed an air leak test, and it was negative. We considered a corticosteroid. If positive, we moved to the first spontaneous breathing trial in pressure support at 0 pressure support, PEEP6, FR2 between 0.3 and 0.4 for 30 minutes. If there was a failure with tidal volume below 6 milliliters per kilogram predicted body weight and respiratory rate higher than 22 and decreasing oxygenation, we got a rest period and then eventually performed a second spontaneous breathing test, this time at 4 centimeters of water of pressure support, and if passed, we extubated following by non-invasive respiratory support. On the other side, if the patient passed the first spontaneous breathing trial immediately at 0 pressure support, we extubated the patient followed by continuous positive airway pressure. So the level of non-invasive respiratory support after extubation was different as considered to patients who passed rapidly or not rapidly the spontaneous breathing trial. Before extubation and after the spontaneous breathing trial, we always performed a so-called rest period with pressure support at 8 for at least 1 hour. Of course, we consider to stop enteral nutrition, agitation and behavior management control, in some cases alveolar recruitment and supraglottic drainage. The key roles here are the respiratory physiotherapy, which is very important in this patient, and the use of post-extubation intermediate unit that we organize next to the larger ICU, in which we admitted patients after 1-2 days of 8 to 10 days before discharge to the infectious disease. And we found that almost 30% of the patients admitted in this area might have some additional problem in terms of oxygenation or coagulation. So overall, COVID-19 is a real serial killer, is a systemic complex disease, is not traditional RDS. The first bullet is pneumonia. This is characterized by the real primary RDS with pneumonia and vascular lysis. A second bullet characterized by coagulation with thrombosis and hemorrhage. And the third bullet, which is characterized by fibrosis. 4 target treatments are to be considered: anti-inflammatory, mainly with corticosteroids when patients start to have respiratory problem and alteration in oxygenation, anticoagulant from prophylactic to therapeutic, antiviral, but only very early, with eventually remdesivir, and protective respiratory support from non-invasive to invasive respiratory support. Local protocols are very important. In critical ill patients, phenotype 3 was more frequent than phenotype 1, as I show you. The inhomogeneous pattern of aeration, blood volume distribution, and perfusion defects characterized this kind of patients, and the pulmonary pattern, the blood volume, and the perfusion defects were associated with clinical outcome, inflammatory, and thrombophilia markers. Hypoxia may be explained by higher compliance with less effort and low VQ in the poorly aerated tissue with higher space and higher ventilation needs. On the other side, the SAD hypoxia is characterized by higher or lower compliance with less of higher effort and shunt in non-aerated tissue, always associated with higher dead space and higher ventilation needs. So lung imaging by CT scan, but also lung ultrasound, might be extremely helpful at bedside in terms with the lung ultrasound for COVID-19 assessment. Finally, how to ventilate COVID-19 patients. You have to be very patient, and I show you that weaning might start sometimes after 10 to 2 weeks of mechanical ventilation. In phenotype 1, non-invasive respiratory support might be used, but early intubation should be always considered if no clinical improvement occurs within 2 to 6 hours. And particularly when respiratory rate is higher than 28 breaths per minute and saturation of oxygen below 95, we refer to a 60%. Also, the use of accessory muscle activity and the lower level of PCO2 might be considered. In phenotype 3 and phenotype 1 not responding to non-invasive respiratory system, early intubation and controlled mechanical ventilation might be immediately considered. Then we should suggest protective tidal volume with between 6 to 8 meters per kilogram predicted body weight and plateau pressure below 27 centimeters of water. We always use P between 8 to 13 centimeters of water at a maximum of 15 centimeters of water, and we use higher level of FiO2 as compared to higher pressure. Recruitment maneuver should be used only as a rescue therapy. Overall, we minimize the oxygen target with a PO2 between 55 to 85 millipare mercury with higher hemoglobin levels for oxygen transport. We have always to control the PCO2 and pH in order to avoid possible negative effects of both effects on saturation and oxygen, especially at minimal level of oxygenation. Finally, in phenotype 3, we tried composition, but we have to remember that there is no recruitment associated with improvement in oxygenation, but this is mainly due to a redistribution of perfusion. And again, since composition is associated with a higher risk of PCO2 and lower pH, the both effects should be always taken into consideration. I think that all this information might be helpful to prepare in each hospital a comprehensive bundle of respiratory therapy in these patients, individualized and according to the pathophysiology of COVID-19 pneumonia. Thank you very much.
Maestro ceremonias.
Bueno, para cerrar esta jornada que ha estado, creo que...
Okay, for closing this session, which has been quite interesting, and
Y
getting
percepción
you to travel from one pole of conception of the pulmonary and extrapulmonary involvement of the COVID patient to the other pole, which leads us to reflect, which means that we still have a ways to go. I don't know how long we have to go before we can truly understand this disease, and so that we understand the typical or atypical ARDS. We have several questions, and due to time constraints, we're going to tackle only 3. The others will be tackled through the chat and the forum. So let's begin with Dr. Pelosi. Dr. Pelosi, I would like to know why did you include non-invasive ventilation with helmet over the high oxygen flow therapy for these patients? And this is for Dr. Pelosi because probably in our institution and in this region, probably we don't have the helmet available on a permanent basis, and it's expensive. In Latin America, it's costly, it's expensive. It is available, but the cost is limiting. And we have the other tool, which probably allows for better familiarization. Maybe it's been more widely disseminated. So I would like to know why you prefer it, since you showed very good results in terms of prevention, in terms of intubation with the helmet.
Just to be simple, since I showed you that we have the hypoxia due to low VQ initially, and sad hypoxia when we have true shunt. So in the initial phase, I think that the best way, the simplest way, is to give oxygen, not PEEP, oxygen, as much as FI2 as you can. And I think we use more the helmet with CPAP, but I am convinced that probably we use too much CPAP. Too much CPAP. So I think first give oxygen even with reservoir. Very simple, very cheap. Second choice might be high flow oxygen nasal therapy that is very comfortable for the patient. And a possible third option is helmet CPAP, but I think that the initial phase is oxygen. Helmet is just because you have a better environment in terms of FiO2. So my message is that to give oxygen in the early phase, but if the patient deteriorates in saturation, I mean saturation below 92, and you need oxygen more than 60%, this means that you are moving to SAD hypoxia, shunt, and this patient should be intubated, of course, if it's possible. So don't wait too much for intubation. But a simple way to give oxygen, I think, is the first choice in most of these patients.
Muchas gracias, Paolo. Muy amable.
Paolo, thank you so much. You're so kind. I hope that clears up all of the other options, such as early options for management prior to intubation. Here we have another question also for you. Okay, for us in Latin America, although we have access to the test, we don't have the availability in terms of scope as well as in terms of economy to do CT angio on these patients regularly. And within the protocol that you have, we know the theoretical benefits, you include it at some point. Okay, somebody said, okay, how has the use of angiotac has affected the therapeutical options in our patients?
Overview on our also pathophysiology studies. We used
Okay.
we use dual perfusion for research also and to understand better. So I don't recommend to use CT perfusion or dual energy, of course, in all patients. But angiotac, we did the angiotac when patients were progressively deteriorating when intubated, because we found that one of the causes is the possible thromboembolism, local thromboembolism. So I don't say that we have to go every day to the angiotac. If it's possible in a deteriorating patient, is interesting. But I think that most important, easier and cheaper is to perform heart ultrasound every day in these patients. And if you see an increase in the dimension of the right ventricle associated with a progressive increase in the dimer, these patients require an increased anticoagulation. Usually we moved from enoxaparin to heparin at 25,000 a day. If the patients have hemodynamic compromise, even if you have not angiotac, I think that in presence of right ventricle impairment, increased in the dimer, and hemodynamic impairment, I think, and deterioration in gas exchange, sometimes we use alteplase, so thrombolytics. So I don't recommend to use angiotac, of course, as a routine. It's just to think that pulmonary embolism is in 6-10% of cases a possible cause of deterioration of gas exchange in these patients.
Perfecto, muchísimas gracias por esa.
Okay, perfect. Thank you so much for that clarification, Paolo. And now let's link with Dr. Alvarez. Okay, Manuel, are you there?
Un enlace de lo que acaba de comentar Paolo muy claramente.
To do a linkage to what Paolo has been saying. Okay, can you hear us?
¿Puedes hablar un poco más duro, por favor?
Okay, can you please speak louder or turn up your volume? Okay, can you guys hear me okay there? Okay, maybe a bit better. I believe it's a matter of volume.
O acércate al micrófono o al sistema.
¿Ahora mismo me escuchan mejor?
Mucho
Can you hear me
mejor.
better now? Okay, much better. Okay.
Perfecto.
Can you hear us?
Listo.
Okay, good.
Acaba, Paolo, porque la voy a
Okay.
unir a otra de las preguntas.
Okay, I'm going to link this to another question which is relevant to mention how we can probably recommend the use of echocardiogram in a given way to do surveillance and monitoring. Manuel is a cardiologist, intensivist, and has faced this pandemic all the time since it started in Colombia. And I would like for Manuel, okay, there was a question
La inquietud de cuándo
that shared the concern about if it should be done transesophageal or transthoracic cardiological assessment, how often should it be done?
Un segundo, Manuel. Entonces, pase para acá. Perfecto. Manuel se encontraba en la institución.
Okay, Manuel is here at the institution. I'm going to repeat the question. Okay, the question, Manuel, is, okay, to link to what Paolo was saying, okay, we talked about angio-CT alone for clinical studies and for research, and we can use echocardiogram. So the question already on the list of questions was when and how often and what type of echo do you do on these patients, knowing that you clearly explained and what Paolo explained and what we've mentioned in terms of the vascular component, which is key in this scenario. Okay, Manuel is now going to step in. Okay, thank you so much. I believe it is important to remember that the echocardiographic measurement on the patient is valuable in terms of critical care, And as Dr. Pelosi mentioned, we need to try to evaluate the right ventricle, and we should always do it with the serial measurement of the dimer. Evaluating the right ventricle in echocardiography may prove useful because we can see changes in the dilation of cavities or a reduction in systolic and right ventricular pressure with tools such as TAPSIS. And if that's the case, we can make decisions not only about the coagulation of the patient, but also other therapies or strategies and complement those with angio, CT angio. But that should always go hand in hand with D-dimer because sometimes there are changes in the D-dimer that leads to changes in the therapy because of the evolution of the cavities or the pressure that can be found with the echocardiogram.
Muchísimas gracias, Manuel, por
Okay, Manuel, thank you so much for the clarification. And there was another question for Manuel, and it is, okay, you showed some algorithms. At times, all of these algorithms generate some type of confusion with the public. We need to read them, memorize them. Okay, in a practical manner, Dr. Alvarez, when do you consider that we should anticoagulate a COVID-19 patient? Okay, I believe that the most important point to remember is the three characteristics from the lab that we have besides the clinical variables that we're going to mention our patients, which is the presence of dimer D, of D-dimer, mostly when it is 6 times higher than the reference value. We're talking about more than 3,000 milligrams per liter. When the time of prothrombin increases depending on the scenario that we have, unless it increases between 3 to 5 seconds, which is about 1.2 DNR to 1.4, or when the platelets are below 100,000. If there are all of those characteristics, we should always try to go anticoagulate our patients. When we have one characteristic, which is the presence of the of the dimer elevated 6 times more, we need to anticoagulate these patients to avoid thrombotic complications when we have those types of D-dimer values. So the anticoagulation scenario should be conditioned to well-documented cases or the previous characteristics coming up in the definitions of intravascular disseminated coagulopathy or sepsis-induced coagulopathy. Dr. Alvarez, one last question, which I believe is valuable to clarify. Okay, what is the role of oral anticoagulants in this scenario? Okay, undoubtedly, within the intrahospital scenario, heparins are superior to oral anticoagulants because of the higher level of interactions, the longer half-life. So in the hospital scenario, we should always prefer heparins over oral anticoagulants. In the outpatient scenario, especially in patients where there's been a thromboembolic event as such, the use of direct anticoagulants may actually be superior as compared not only to low molecular weight heparins, but also vitamin K antagonists such as warfarin. So in this scenario, we can use direct action oral anticoagulants for patients who can benefit from this kind of therapy for at least 3 months. Okay, Dr. Alvarez, thank you so much. Okay, and to finish off the session, Dr. Carrizosa, we have one question for you. Dr. Carrizosa, are you here?
Listo, Jorge, muchas gracias. Jorge, usted hizo una revisión.
Jorge, you did a review which was quite thorough of all the tools we have for evaluating the drive and the patient's inspiratory effort. So someone asks how we can evaluate the inspiratory effort. Maybe we have tools for that when the patient has been intubated. You mentioned that clearly, but what would you recommend to evaluate the inspiratory effort in non-intubated patients? Okay, given the fact that Given the fact that the patient is with non-invasive support, the essential tool is going to continue to be the clinical data, how that effort looks in the patient, if there are signs compatible with breathing distress, respiratory distress, if there's any nasal flapping or accessory muscles, and then diaphragmatic ultrasound and respiratory muscles if you want to be more thorough. Very quickly, we saw yesterday how to evaluate the diaphragmatic excursion, the contraction of the diaphragm by means of the position area, but we can also evaluate the contraction of the intercostal muscles and the active effort being made by the patient with the support of the abdominalis muscles. We could quantify before the patient gets to a point of thoracoabdominal disassociation. We should identify with the contraction of the rectus and the transversus abdominis that that patient is probably going to progress to a respiratory, secondary respiratory failure, to an excessive effort that the patient is making, and we should not let him make any progress, but we have to intubate as soon as possible. Okay, excellent response. I believe that we were all waiting for that. ECHO has found a niche in the ICU, and it's a practical and useful tool. We should all learn to do it, and the clinical data should prevail over the tools. Those that don't have ECHO should do objective clinical surveillance on a continuous basis. I think that the strongest message is not to forget that the inspiratory efforts should be included into the monitoring or the tools of the variables to be monitored in our ICU patients, whether or not they are intubated. Okay, thank you so much. I want to thank all the speakers, and I believe that we went a little bit over time because of the number of questions that we had. It is the first day of this online conference. We hope you liked it a lot. We've enjoyed it quite a bit, and we will get together again at 8 in the morning. For those who want to rewatch some of the talks, you can watch them in either Spanish or English as of 5 p.m. The broadcast is going to be done in the very same sequence as this morning so that you can enjoy them, or if you want to repeat the viewing of any of these conference talks. From 5 p.m., they are going to come up on the online classroom box with academic resources. And there is a book that is making us very proud and that we want to share with all of you. Okay, have a happy afternoon, happy lunch, and we'll see you tomorrow at 8 in the morning. I want to thank the speakers for their assistance, and I want to thank all attendees for the time they've shared with all of us. Thank you.
Hola Juan, tienes bastante retorno.
Sí, sí, 300, sí. 300, claro. Sí, pero no va más.
Hola Juan, ¿me escuchas?
Sí te escucho, pero si tenemos acá amplificación, tenemos retorno.
Ah, ok, listo. ¿Paso a seguir? ¿Cerramos aquí o...?
No, ya terminamos por hoy. Toca es hacer la revisión del link de
Sí,
inglés
claro.
que quede funcionando bien, que ya Miguel está trabajando en eso.
Claro, sí. Ya por lo menos para mañana ya está eso cuadrado.
Jorge, Eduardo,